But like Tamara, I would like to thank the leadership of the Doheny Eye Institute and for really the honor and the very personal pleasure of being here this morning. It's really, for me, a real joy to see this fantastic partnership between the Jules Stein Eye Institute and Doheny Eye Institute, which are really two of, not just my personal opinion, but I think the entire country, is really two of ophthalmology's treasures. Have been and will continue to be for a very, very long period of time. And I think we all know, as has been reflected, that the Doheny Eye Institute is really the child of some really great leaders in our profession. Some, like Alfredo, are here today. Some are not. And this meeting has always meant to celebrate the accomplishments of the faculty, the alumni of the Doheny Eye Institute. And I think that it certainly does so today, and everyone who has been associated with Doheny should be very, very proud. And it also really showcases the Distinguished Alumnus Award, and I'm delighted to see Tamara doing this, because there are very few people who have given as much to our profession, and she carries forward a very proud tradition. So what I'm going to, but after I talk today, we may want to reprise that marijuana talk, because I am going to, I think, unfortunately, lead some of you somewhat depressed when we get through with this. But I will say that if I asked you how many of you think you'll still be in practice in January, if you're going to be in practice in January, what I'm about to say should be very, very important to you. So again, I have no relevant financial disclosures. I'm going to start with this slide. And this just talks about the integration in healthcare in the United States. And what we are in the midst of right now is not an overnight phenomenon, but something that's been going on for a long time. And if you look at, this is the latest data I was able to get, was as of October 2015, that 24% of all M&A deals in the United States were in healthcare at that point. And you just look at the dollar figures alone: $250 billion in pharma and biotech, $25 billion in hospital M&As, the tie-ups between Aetna, Humana, and things like this that, if they totally go through as planned, are going to leave 3 U.S. mega insurance companies: Walgreens and Rite Aid, with 13,000 locations, $100 billion in revenue. This is not your grandfather's healthcare system. This was not the way it used to be. This is not the result of the Affordable Care Act. It may have accelerated that process. But people say, well, it's kind of a byproduct. No, it was absolutely intended. And I always love this quote, in a sad way, from Nancy Ann DeParle, who really was one of the key forces behind healthcare reform in the current administration. And she very clearly put it in the Annals of Internal Medicine in 2010, same year the Affordable Care Act was signed, that this was meant to accelerate this process. So none of what's going on is an unintended consequence. And the current Secretary of Health and Human Services is linking this now to the quality transformative process that I'd like to speak to this morning. Now, people say occasionally, well, gee, the Affordable Care Act hasn't done anything good. Well, it may not have, quote, done anything good in somebody's opinion, but it certainly has been followed by some very interesting statistics. And what you see here across the bar are positive changes in hospital-acquired conditions in so many different things: catheter-associated UTIs, falls, pressure ulcers, etc. Now, as Tamara said, many of these are system issues, and many of them have to do with doing some fairly simple things, the timeouts of the world, for example. But the point is that there is an increasing emphasis on quality, and this is now all being linked into payment and value. And just about everybody who are the major stakeholders in healthcare reform these days believe that the only way to increase the value of U.S. healthcare is to pay for value in care as opposed to the volume of services delivered. And this so-called volume to value, or V to V transition, is one of the major drivers in everything that is going on right now. So my objectives this morning are really to sort of talk a little bit about what is value in healthcare, how is it going to be measured, and what are the short and long-term implications for healthcare in general and ophthalmologists specifically. Now, when we talk about value in healthcare, a lot of people use this phrase up top, that it's basically quality divided by cost. It's very simple, it's easy to understand. It's actually a little bit more complex than that. And another way to look at it is the healthcare outcomes, okay? So we're not talking about processes, we're talking about outcomes achieved per dollar spent. And that's the way that healthcare economists like to look at value. So it all seems pretty simple, but when you analyze, as with any very simple equation, the factors, for instance, for quality, who's going to determine it, okay? Are the metrics clinically relevant? Very, very important thing for all of us as clinicians. Are they risk adjusted? When you see severe patients, should that be counted as opposed to very non-complicated patients? Data points, what's the reporting burden? Every physician in this room who's seeing patients would not hesitate to raise his or her hand that the regulatory burden, reporting burden that we face now is greater now than it was 5 years ago. And then the whole issue of cost. Cost is very, very complex. What are you including in the cost bucket? Is it just physician services, facilities, drugs, et cetera? Who's going to collect the data and how is it collected? And then you're looking are we talking about total cost or that portion of the cost that the physician really determines? You may think these at this point are sort of abstract concepts, but right now, every physician in this room who's seeing patients is being measured by commercial carriers and by Medicare on these two factors, quality and cost. You don't know it, but you really are. And you have no way of knowing, nor do I, whether the algorithm being used by the particular commercial insurance carrier is in fact risk adjusting it, or what's in that bucket of costs that are being attributed to you. So this becomes much, much more than just an abstract issue. So I come back to this famous saying, which has been incorrectly attributed to Albert Einstein, which is that not everything that can be counted counts, not everything that counts can be counted. So that what it means is that you can't over-granularize this in terms of trying to see, gee, what does that swab cost, because it really doesn't count. On the other hand, what's the quality of the patient's vision? What's the impact on the patient's daily living is something which is difficult, not impossible, but difficult to actually count. And what if the whole process goes wrong? As I would argue to you, it is to a certain extent. If you use inappropriate metrics, you're incentivizing inappropriate behavior. We all know this in our own lives, even with raising children. If you try to drive a certain type of behavior by incentivizing it, you'll get it. Now, it may not be that you're driving the right thing. If you record the outcomes inappropriately, you may be doing the right thing, but not getting the credit for it, okay? So in other words, if you're checking post-op visual acuity at the wrong point in time, you really may not be checking the right thing. And then you may not risk adjust. And many people in this room who are in tertiary practices are dealing with a higher acuity in terms of comorbidity than someone who, let's say, is just dealing with a non-selected patient population. So we have a whole lot of things involved in measuring the right stuff, if you will. It's interesting. If you were to take a look at this, and this can be ophthalmology, this can be general surgery, it can be anything. If you were to decide for yourself which of these are the most important factors in surgery? The judgment as to whether to operate or not, which procedure to perform, the intraoperative technical skills, or whether guidelines are followed for antimicrobial prophylaxis. We'd probably all be choosing one of the first three. The only one that is currently actually measured is the fourth one, okay? Which shows you right away that we have this disconnect on the issue of clinical relevance. And this is embedded in most of the algorithms which is being used by the companies that build the algorithms for commercial insurers. So if you look at a healthcare value decision-making grid, it's really fairly straightforward. If you've got a higher outcome at lower cost, you want to encourage as much of that as possible. On the other hand, if you've got bad outcomes and high cost, you want to eliminate it. The others, low outcome, low cost, you may choose to ignore. The high outcome, higher cost, that's where things get dicey. And we can all think of this with ophthalmologic parallels. Femtosecond laser. Where does femtosecond laser belong on this thing? Okay. Where does Avastin or bevacizumab go versus aflibercept? Okay. We all make these choices all the time, and it's really, in a sense, this grid which drives everything. So how does system design affect this? Well, co-payments, okay, pre-approvals, the required failure of a less expensive option, again, bevacizumab versus ranibizumab, for example. So there are a lot of things in system design now that are being looked at to drive volume versus value. And there's the whole issue of low-value care, okay? Let's talk about the concept of doing knee arthroscopies for minimal symptoms. A lot of it is not just the physician, it's also the patient. As Tamara pointed out, the patient is not involved many times in the medical errors, but the patient is very, very much involved in what choices in the healthcare pathway we all pass down. And we know very well that some of the things that are done now, particularly in the EHR environment with decision support tools, doctor, do you really want to do this? The prior authorizations, the penalties involved in paper performance, all of these are trying to drive physicians away from low value, low cost care so that more and more of the healthcare dollar can be spent in the high value portion. Why? Because there's so much of this going on. One of the things that's also happening, which is critical, is in this volume to value, is a tax on the RVRVS. I think that every retina specialist and glaucoma specialist in this room is familiar with the cuts in reimbursement recently and is wondering how could this possibly be happening. Well, what's happening is because I think, as we all know, relative value units are based on practice expense, work, and medical malpractice cost with a conversion factor applied to them. Historically, the work RVU has driven the payment, which is why in many of our systems, large organizations, compensation of physicians has been linked to work RVUs. And work RVUs have historically been composed of time and intensity of service. But because now the government is trying to get rid of misvalued, aka overvalued codes, the whole issue of intensity is dropping out. And there's a desire to basically, just as we see right now in national politics, quote, reduce income disparity in medicine by eliminating this intensity component, such that if it takes 20 minutes to do a bunion and it takes 20 minutes to do a trabeculectomy, they should be paid the same because they take the same amount of work. That is one of the policy drivers that's going on right now. And at the same time, they're reevaluating times. And some of the procedures in ophthalmology have not been reevaluated for almost 2 decades. And as we all know, the time it took to do any procedure in ophthalmology in mid-1990s is a whole lot longer than it takes right now. And so some of these are just happening as the data gets updated. But the overarching objective, policy objective, of all of this that's going on is to basically drive physicians out of fee-for-service medicine, and by reducing per-service payments. And when we go to Capitol Hill and we say, you know, gee, this is not good for medicine, this particular slide gets thrown up. And this is a slide of mean incomes, annual mean wage for various things. And at the very top of this, everything that's in pink here are healthcare professionals. The green line is CEOs, corporate CEOs, and other corporate officers. And the orange one is petroleum engineers. These are the top mean incomes by profession in the United States. We, by the way, are where that red arrow I put on the side are. So we don't get a lot of love when we go to Washington and start complaining about changes in income. And they go, it's because you've been working in a volume-based system. You're now going to be working in a value-based system. Which brings me to MACRA. MACRA was passed in 2015, repealed the sustainable growth rate methodology. And I would proffer to you that this is going to have a bigger impact on the delivery of health care in the United States than any health care legislation we've ever had, including the 1960s Medicare Act. And the reason for that is that for the very first time, it doesn't just change how much is being paid, but it fundamentally determines and updates the payments to physicians, the goal being, again, to move from a per procedure, a volume-based system, to a value-based system. And I would remind you that when this was passed in the House and Senate, it was overwhelming in both bodies. In the Senate, it was passed 92-8. Nothing in Washington happens at 92-8. And so this gives you some idea of the appetite for fundamental change. And it incentivizes the development and participation in what's known as alternative payment models. But it also establishes the legacy pathway, the fee-for-service pathway, as what's now called MIPS, or the Merit-Based Incentive Payment System. And when you get down, we're dealing with all these incredible acronyms all the time, and so it's not at all surprising that we have this sort of deer in the headlight sort of approach when we're faced with all these new acronyms. And I will tell you, the rule that just came out a month ago that's going to implement the MACRA Act, the proposed rule was 965 pages long. We have 60 days to respond to it. The comments will be taken into account by Medicare. They will be issued as a final rule, probably the last week in October, and it goes live January 1. This is an incredibly short time frame for what is the most transformative bill in U.S. healthcare ever. And as I said, it's going to be January 17. And what you do in 2017, you will be paid for in 2019. And of those two pathways, the MIPS and the APM, MIPS is the only one in the near future that is going to work at all for ophthalmology. Now, occasionally there'll be some refractive surgeons or some oculoplastic surgeons in the room who will say, well, I'm sure glad I'm not involved with Medicare. And the issue, however, is that the commercial carriers are already indicating they're going to follow Medicare. So this is not going to be just a Medicare phenomenon. It's going to be basically all of what we do except direct payment from patients. So a couple of words about MIPS. MIPS, and again, this is what every ophthalmologist in this room effectively is going to be paid under as of January, has four components. The first is what they call quality measurement, which replaces the old PQRS. The second is resource use, which replaces the old value-based modifier. And think of that as cost. Whenever someone in Washington says, I'd like to talk about resource use, they're saying, I want to talk about cost. EHR, meaningful use. And then finally, clinical practice improvement activities. These four things are the components. Now, how are they weighted? If you look here, you'll see that the quality measures and resource use are going to be the big drivers. Quality, cost. Meaningful use is going to gradually drop off, and the clinical practice thing, by the way, is not something that we really need to worry about. Most everybody in this room is going to be able to attest to it. Now, here's where things get particularly interesting. And I talked earlier about what are we measuring? What actually constitutes quality? And that has to do with the whole concept of measure development. And some of you in this room have worked with the Academy in the measure development process. And before IRIS, these things were generated by panels of experts. They were valenced by the literature. They had to be validated. They were submitted from multiple levels of federal review. They cost the Academy 2 years of time and $100,000 per measure. Okay. And we developed a lot of these measures. And so when you wonder where your dues go, this is one place they were going. Because this is what we are all being judged by. Now, fortunately, in the IRIS world that we have now, we can actually generate these through IRIS, and they take only about 6 months and less than $10,000 per measure. So what does that mean? We are able to, for the first time, to give the neuro-ophthalmologists or the pediatric ophthalmologists or the uveitis specialists something by which that they can use to be measured to qualify for bonuses and to avoid payment penalties. Incredibly important. And so how much of these penalties that we're going to be seeing as of January? As you can see, they go up fairly rapidly to 9% because 2022 means what happens in 2019. That's not that far around the corner. And that's going to be a plus or minus 9% of your total payments from Medicare. And again, the commercial payers are going to be following this more than likely at this point. And there are some additional exceptional payment things. But the point is, it's real money. And just to show you again, to remind you that when they say, well, MIPS doesn't start until payment doesn't start until 2019, it's what happens in 2017. So everything sort of falls back 2 years. People ask, well, really, is ophthalmology too small to matter? Can't we just kind of work on our own way on the side? In fact, we have 2 of the top 20 diseases under Medicare, cataract and glaucoma, in terms of total cost. If we add drug costs, we add macular degeneration, diabetic retinopathy, and therefore I have 4 of the top 20. We are very much on the healthcare economists and CMS radar screen, okay? Total payments to ophthalmologists for professional services to Medicare patients, including Medicare Advantage, including the patient component, et cetera, drugs, $9.5 billion. We are far more than a rounding error. And just to give you one example, the retina people will enjoy this. This is the fastest growing code in all of medicine. In 2002, just 14 years ago, we did a little over 4,000 of these. Some people in this room probably do over 4,000 a year by themselves now. And we estimate in 2015 that there were about 5 million intravitreal injections done in the United States. And I'm sure many of the retina people, as kind of I did, have some days when you think you're not doing anything but injections. So we are much, much more than a rounding error. Interestingly, currently it's said to take 22 minutes. The federal government estimates it takes 22 minutes. Anybody in this room who takes 22 minutes to do an intravitreal injection has got a real problem. It has the second highest intensity of any one of the thousands of codes in medicine except emergency intubation. So anybody who thinks that this is not going to be whacked the next time it goes to Medicare is wrong. And it's going to be issues. Now, I'm occasionally asked, is this going to change after the elections? It is absolutely not going to change in any fundamental way, regardless of who's in the White House. And why? Because the purchasers of health care want this sort of thing. And this list was put together by Bill Kramer. Bill Kramer is the Executive Director for Health Policy of the Pacific Business Group on Health. They're a small group consortium of employers that include things like Apple, Google, GE, Boeing, Walmart, things like this. They control 11 million covered lives. And this is what they're looking for. They think our old system, which was not a value-based system, is not going to work going forward. And this was a very interesting survey that shows that if you look at that lower left one, those light blue bars are basically the percent of a commercial payers who access commercial insurance who are going to base more than 50% of their business on value-based models, okay? And you can see how that's growing over time. And so the employer community is adopting this. This is one of my favorite slides for this. It's talking about colonoscopies in the San Francisco Bay Area. And you might ask, well, why are colonoscopies relevant? Well, to a certain extent, talking about payment in healthcare is a little bit like having a colonoscopy. But this is one of the best examples out there of what's big data is being used now for value-based healthcare. This is the range of total costs of a colonoscopy of all the centers in the San Francisco Bay Area that were judged to be high quality, okay? So they had already sort of gone above the quality threshold. And you notice a range for between $887 and $8,650. Now, if you're Google, and what are you going to do? You go to Pacific Business Group on Health and you say, what do we do? What Pacific Business Group on Health did, so this is really simple. We're going to pick a number in the middle, and I think they picked $3,000. And they said, if you have a colonoscopy and it costs less than $3,000, we will pick up everything. No copay, no deductible, we'll pick up everything. Because we know we've already vetted these for quality, and we're just going to pick the slightly greater than half that are on the low end. If you want to go to the one that costs $8,650, you're on the hook for $5,650. This is called reference-based pricing. You want to know what happened after they did this? All the ones to the right of the line moved to the left. Okay. It really shows you the power of the purchasers of healthcare right now using very simple techniques, which are like reference-based pricing. But remember, reference-based pricing has as its beginning point that you've done a quality assessment, okay? And now you're driving value, okay? So what do ophthalmologists do under these circumstances? Our biggest hope, quite frankly, is IRIS, the clinical data registry in ophthalmology. It's because it is written into the MACRA Act, okay? The Secretary shall encourage the use of qualified clinical data registries in carrying out the section. This is our mechanism for quality reporting. And we're trying to get it even more tightly aligned in the final rules, because it will automatically report everything except the resource use and can be adapted to report the resource use. So that means the administrative burden for ophthalmologists goes to zero because it's an automatic process, okay? All the ophthalmologist has to do is say, I want my numbers reported, and they're automatically reported. As of mid-May, this is an amazing statistic. There's almost 12,000 ophthalmologists around the country using IRIS, okay? And we now have, actually now, over 90 million patient records in IRIS. We're going to hit 100 million by September 1. And according to the Pew Charitable Trust that monitors these things, it's now the world's largest clinical registry. And CMS uses it as their example of how it should be done. So what this gives ophthalmologists the potential to do is actually comply with so many of the reporting requirements under MIPS and avoid penalties and qualify for bonuses. And this is an example of what it's done already. If you look at the number on the far right, this is the amount of money that IRIS has saved each year American ophthalmologists in penalty avoidance and qualifying for bonuses. You can imagine the phone call I got from one group that said, we'd just like you to know that we didn't know we were going to get this. We just did everything through IRIS. And our group of 14 people qualified for a $700,000 bonus. That's big money. And so the point is that this really works, and it may help us relative to a lot of other specialties. But the point is we still have to work underneath this system. And so the actual average impact per ophthalmologist in the U.S. is last year was over $20,000 for something that is free, which isn't a bad ROI these days. Okay. So in conclusion, what I'd like to do is to tell you that I think there's no way we're going to turn back the clock on volume to value. The system is fantastically complex, embedded in these 965 pages. There are going to be winners and losers in this thing. But we think, and the group of us met in Chicago last weekend, spent the weekend doing nothing but dealing with MIPS implementation. We think that we're going to be in better shape than a lot of the other specialties because each of us, has a tool which is not only useful for improving the quality of the care we deliver, but also in complying with this whole volume to value system. And so MACRA was to a certain extent a deal with the devil, but the alternatives, had we not gone through this, were much worse. And fee-for-service as we knew it is dead as of January 1. But fee-for-service with a value and resource use component is going to continue for the foreseeable future under the MIPS program. We're going to be pushed to alternative payment methodologies, but right now those are way too uncertain, way too complex, and except for very few employed physicians, not something which is going to be worthwhile. The final thing is, again, that I think IRIS is going to be our salvation. So once again, I'd like to thank you all for the opportunity to be here. Ron always enjoyed raising a glass, and if I had one, I'd raise a glass to all of you. Thank you.